wanted to be part of it and get their perspectives on with us. And we will try to get as many perspectives as possible as we can. We are taking questions, and you can go to slido.com, and the event code is WBUR VTH3. We've already had some great questions submitted, and we will try to get to as many of those as possible. And I guess, I don't know, if there's one way to start, I might say that if there's one thing that this pandemic has demonstrated pretty profoundly is where our weaknesses are, right? We've seen weaknesses in our healthcare system, our supply chains. Who even knew what supply chains were before? Our economy, our housing, our criminal justice system. And sometimes I think many of us are probably thinking, who's writing this novel, right? I mean, it seems like it's affecting all of us in so many strange ways. So we're hoping that we will be able to talk about some of this, some of how these systems are affected, and some of these inequities that have been brought to the forefront and now have to be dealt with. So I'm going to turn it over to Lynn.
Thank you, Deb. And thank you all for joining us tonight. We're happy to have you with us, even though we can't see any of you. Focusing on the homeless community now, there are about 18,000 people who are homeless in Massachusetts right now. Those include unaccompanied youth under the age of 25, families with children, and adults, individual adults, who are staying either on the streets or in emergency adult shelters. And for the purposes of this conversation, we're going to focus mainly on those adults who are in emergency shelters because they are at the most risk, although of course everyone living in congregate living situations is at increased risk. And now I would like to introduce Dr. Jim OConnell. For 35 years, he has been Boston's street doctor. He's the founding physician of Boston Healthcare for the Homeless program. Dr. OConnell and his colleagues have built that program from an organization of 6 people to one of more than 500. Healthcare for the Homeless operates clinics at Massachusetts General Hospital and Boston Medical Center, as well as at more than 40 shelters and soup kitchens in Boston and neighboring communities. It runs a 104-bed medical respite at the Barbara McInnes House, which is part of its headquarters in the south end of Boston, and it brings medical care to people where they are on the streets, under bridges, and in downtown doorways. Dr. OConnell, thanks so much for joining us.
I'm thrilled to be here. Thanks, Lynn.
And first, I'd like to talk about, the messages that we've all heard, these nonstop messages to practice social distancing, wash your hands a lot. Obviously, that's not easy for people who are living in shelter situations. I'd like to show everyone a picture of the inside of Pine Street Inn, the men's dorm at Pine Street Inn. If we can show that, we have a picture from earlier on a few years ago when we were there working on a story, and it shows what the men's dorm looks like normally with beds crowded together. Right now, there are plastic curtains hanging between those beds. Pine Street Inn has hung plastic curtains. The beds are further apart. About 200 people, close to 200, have been moved out of the shelter into a Suffolk University dorm to help spread out the population. And they've installed portable hand washing stations. They've staggered meal times. They've done all kinds of things to try to contain the spread of the virus. But Dr. OConnell, could you talk about some of the things other than the obvious reasons that it would be easy for a respiratory virus to spread in the homeless community in shelter? Can you talk about some of the other factors that contribute to that?
Sure, I'd be happy to. And I should first of all say thank you to everyone for hosting this forum, because I agree that when you look at vulnerable populations, I think both prisons and homeless shelters teach us the weaknesses in our healthcare system, particularly early on. But I've been blessed, the whole 35 years that I've been doing this job, I've been part of a program that works very closely with the shelter community, with the hospital community. And I think one of the things we are learning when you hit crises like this is it's the long-term relationships allow us to not only communicate well, but to work really well together. So we're blessed with a mayor and a governor who really have been superb in addressing this epidemic or pandemic. What is true, though, is, and I would want to emphasize this, the shelter system in Boston has got a long and rich history and is one of the best in the country. We have about 90% of our homeless adults living in the shelter and only about 10% or even less who live outside. Contrast that with cities with nicer climates, and maybe on the West Coast where Los Angeles and San Francisco have most of their people living outside in very few shelter spaces. So the quality of life in Boston for homeless folks is actually relatively good. The downside of this is when the really well-run shelters run into a virus like this, they become the opposite of healthy. And what we need to do with the virus, as you said, is move people apart, have sort of decant the shelters in some way so there's more space. And then you have to remember that in the shelters, not only is the virus going to be able to spread easily, there's not enough facilities to wash your hands every 10 or 15 minutes. If you've got only 4 or 5 sinks for 100 or 200 people. But it's also the people that are there are often people that have struggled the most, struggle with a lot of medical problems, psychiatric problems, substance use disorder issues, and they are very vulnerable. So for example, when we look at our leading causes of death of people living in shelters and on the streets, cancer and heart disease and liver disease are right up there at near the top. So these are very vulnerable folks. So when a virus comes, they generally are considered to be pretty weakened and very vulnerable, having the comorbidities that let people get sick. So we've been frightened to death about this epidemic coming. And it reminds me of, when I first started, it was the AIDS epidemic. We had a multi-drug TB outbreak soon after we started. And then we've had to face, other things like meningococcus and hepatitis C and H1N1. So when these come, it's really terrifying for us who are working in and around shelters. And as you said, Lynn, it highlights for us how we really need something better in the long run than a shelter system with a lot of people warehoused. Although in the absence of anything else, the shelters have been life-saving for us.
And you're working with a lot of people who are dealing with challenges, including mental health issues and substance use disorder. How has the virus behaved? Has it behaved in ways that you expected, or what has surprised you the most about how the coronavirus has spread in these adult shelter settings?
What I think we're learning is that this virus has been unpredictable, and we still have a whole lot to learn. So anything I say tonight, I sort of say as our experience. And so we were expecting to see a lot of the virus to hit the homeless community and be pretty devastating. We didn't know how fast it would travel or how far it would travel. And so we have been surprised that the extent to which the virus has permeated the shelter system. And I think it comes in parallel with the surge in Massachusetts. So we're seeing all across the state, actually, homeless people in shelters with large numbers turning positive. And I think if it's okay to say now, one of the things that happened, we had not seen anybody who was sick up until about March 20th. We were pretty confused at why we hadn't seen more COVID positive folks in the shelters. And it turns out that the screening system that we use to get people to testing may not be as accurate when you're looking at a shelter and perhaps as a prison or a nursing home as in the general population. So when we had a small cluster of about 6 cases of people who turned positive in late March, they tended to cluster or had some contact with Pine Street Inn. So with the help of the shelter folks and the Department of Public Health at the city and the state level, we decided to test everybody there. And in one night or 2 nights in early February, we tested all 408 people who were guests at the inn. And much to our surprise, 147 now turned positive. And that was truly surprising to us. We were not expecting anywhere near that extent. I think at the time we only knew of about 20 or 22 other cases of COVID in the whole homeless population of Boston. So that was our first shock.
I'm sorry, we should say that was the beginning of April. You did that testing, and we do have a graphic showing those numbers. There were 408 people tested in that cohort, and as you mentioned, 147 or 36% tested positive. And as you have said, most of them were asymptomatic. So we can get into that more later, and we'll get to Deb and Liz in a second. But just to follow up on what you said about the screening you had been using, that means you were screening people coming in the doors of the shelters for symptoms, fevers over a certain degree, coughs, shortness of breath, and that sort of thing. And what you found is that was essentially useless. So we can chat a little bit more about that maybe later, but we'll go to Deb now.
Okay. Well, I want to say welcome to Lizz Matos. As we said, she's Executive Director of Prisoners Legal Services in Massachusetts, and just for simplicity's sake, a group that advocates for prisoners across the state. So, Lizz, thanks so much for being with us.
Yeah, it's great to be here. Thanks so much for having me.
So I guess, Jim said something really interesting, right? We don't know a lot about what's going on here, how this virus is transmitted, who gets sicker than someone else. There are a lot of uncertainties, but one thing everyone agrees on is people need to be kept apart. And how do you do that in situations like shelters and jails and prisons? It's incredibly challenging and trying to keep people safe. So I'm wondering, Lizz, there are about between 14 and 15,000 people incarcerated in state jails and prisons in Massachusetts at this time. And I'm wondering what you're hearing from folks who are incarcerated about their experience and about the knowledge that we have right now about how this is affecting prisons and jails.
Sure. So we get calls on a daily basis from people who are incarcerated across the state in both county facilities and the county jails and in the Department of Correction, which is the state system. And we receive calls and emails and messages from family members on a daily basis as well, incredibly concerned for their loved ones, as we all can imagine. Our clients are reporting an array of things. Really, it seems to, especially in the counties, depend on a matter of geography in terms of whether or not you have access to masks or regular access to hand sanitizer, how often you're able to clean your area, whether or not you are eating in a chow hall, for example. So that speaks to just the number of sheriffs doing things differently. And some, of course, have been more aggressive than others, but we've seen that doesn't necessarily yield the results that we're looking for. I think in the beginning of all of this, DOC administrators and sheriffs also thought that they really had the situation under control. They were just doing a lot around preventative hygiene and checking officers or asking officers questions and staff questions before coming in. But we have seen that has not kept the virus out. And even in counties like Middlesex County and Franklin County, where they have been a little more aggressive early on, we have still seen that the numbers have been high there of people contracting COVID. And I think that's just because of the social distancing issue and the nature of how incredibly contagious this virus is. In the fact that people transmit it when they're asymptomatic, as we were just discussing. And so in the DOC, I think right now, we're mostly hearing about how frustrated people are because they've been on lockdown 23 and a half hours per day without going outside for a month or longer now. And people are really starting to deteriorate mental health wise, and they're extremely stressed out about whether or not they have COVID, and have seen people being sick around them. So right now, the DOC is starting to test prisoners in all of the state facilities. And I think people feel somewhat grateful for that, although other people are actually refusing tests because they're afraid that they'll be placed in solitary confinement.
So let's talk a little bit about what we know about infections in jails and prisons. And I think that we have a graphic based on some relatively new data from the Department of Correction, which shows the infection rate in DOC facilities that we've charted here at WBUR. And the DOC, the Department of Correction, holds about half of the folks incarcerated in the state. So this is not county jails. But since the first infection was reported in a state prison on March 21st, you can see how it's climbed. The dips here are because the numbers from the Department of Correction that day may have subtracted folks recovered or folks who died. And currently there are 7 reported prisoner deaths in Massachusetts. So the rate has gone up considerably. But Lizz, you mentioned testing. So I'm wondering how accurate is this rate? If we're saying 170 to 180 people in the Department of Correction currently positive right now that we know of, and you mentioned DOC is starting to test folks. Mm-hmm. Is there enough testing going on right now, and what do we know about that?
So I think what we know is that the testing does not reflect who is positive, right? Because we saw, and this is partly reflected in your graph, but on the 22nd, which was last Wednesday, there were 296 prisoners and staff that had been tested in the DOC. And then on the 25th of April, there were 733 tests that had been conducted, but the numbers jumped precipitously just days after the DOC had tested most of the women at NCI Framingham and most of the men at NCI Shirley. And so I think that shows that testing demonstrates that there are far more people who are positive than we knew of before. So the numbers, and the graph shows right at the end in the last few days that there's been a huge jump in the numbers of people who are testing COVID positive.
We have a quick question here that I just want to do as a follow-up, because we talked about DOC numbers from the Department of Correction, but we got a question on Slido from Raphael. And he apparently has been following this closely because he's been looking at numbers. And his question is, what about some sheriffs who are not testing prisoners? So can a facility just say, I'm not testing?
Yeah, and until they're ordered to do so, there are a number of counties, a number of sheriffs who have not tested any prisoners in their county, and that is, of course, problematic given what we know about asymptomatic transmission. And then there are other sheriffs, like I said, who are being more aggressive in testing more people. But still, I'd say by and large, with the exception now of the DOC, which is the only correctional entity doing universal testing, I think sheriffs are afraid to do more testing, or they haven't really been instructed to, because the CDC guidelines initially anyway said that you shouldn't be testing people unless they're symptomatic, or they have this many symptoms, or they've tested negative for the flu, or whatever it is. So the criteria for testing was, I think, very high in the very beginning, and it's still left up to the sheriffs as to who they decide they want to test. So that, of course, is not going to give us an accurate picture of what's going on inside.
Okay.
We'd like to remind everybody that we're taking questions on Slido throughout this event. You can go to slido.com and enter event code WBUR-VTH3. And we have already received lots of great questions, so we will try to do our best to get to as many as we can. And again, we are live streaming with Lizz Matos of Prisoners Legal Services of Massachusetts and Dr. Jim OConnell, president of Boston Healthcare for the Homeless program. And Dr. OConnell, getting back to what you found in Boston in terms of asymptomatic spread in one of the major shelters in the city, we should mention that Boston is certainly not the only place this has been found. I'd like to mention a shelter in Worcester, the main emergency shelter in Worcester, where we did visit earlier in the winter. So we have a photo that you can see, just kind of get a sense of what the common area, the dining area normally looks like when there's a large crowd gathered there. Again, this was earlier in the winter before the coronavirus pandemic had started, and the photos you're seeing this evening are by WBUR's Jesse Costa. Just recently, Worcester did test everybody at this shelter and found, again, a high rate of asymptomatic spread. 43% of the people who were tested at that shelter turned up to be positive for the coronavirus. And the doctor from UMass who led that testing told us that people were either asymptomatic or very minimally symptomatic. So what do you know? What do you think about why the virus is presenting this way so much in the homeless community? Or could it be that it's presenting this way in the general population as well, but we're just not doing enough testing of people in the general population who don't have symptoms to really know what that rate is?
Well, Lynn, that's a great question, because one thing we are very hampered by is we have not tested the general population. So we only know the tip of the iceberg of this pandemic, and we don't know what the vast majority under the surface is. So we were certainly surprised when we tested everybody at Pine Street, but when we thought about it, the vast majority, 88%, and I should add, this is a study that was carefully done. It was, first of all, it was orchestrated by Jessie Gaeta, who's our amazing chief medical officer, and it was her creative juices that got us to do something like this. And the evaluation is done by another fabulous doctor of ours named Travis Baggett, and he's the one who is doing all the evaluations and looking at these things. So I feel a little bit like I'm their spokesperson here, and I should acknowledge that. But what we found is that virtually no one person had a slight fever. We screened everybody the same night we tested, and only about 10 or 11 or 12% at most offered some version of a symptom, and all the rest had no idea they were sick. They had at best just mild stuff. That was as surprising to us as the number that tested positive. And we've sort of looked at that since then, even though we haven't got a really rigorous study at this point, but it looks like most of them continued. Since we took care of most of them, or many of them, they went on to not develop significant symptoms during the next week or two, suggesting that this is a milder version of COVID, and we're not sure why. We were expecting this population in particular to get very sick. So it's a mystery to us, and I hope we'll learn something about it. I know the CDC and the state departments of public health are very, very interested in what's going on.
And is it true that we really don't know the rate of asymptomatic spread in the general population, because that kind of testing is not happening on a wide scale?
No, and I know I should say this because we were all a little baffled when we first learned about the coronavirus coming from Wuhan. It was thought to be entirely passed by symptomatic people, which is why we've set up in our country pretty much a symptom triggered testing system. But when you look behind the scene and start to learn more, I can certainly say that most places we look, a good number of people who come down with the virus have been asymptomatic. And I just read a study from Iceland you might have seen yesterday, where half of Iceland, when they did all their studies, half of the people in Iceland were asymptomatic. So I think asymptomatic spread is something we need to really cope with and haven't really dealt with yet. It's so new to all of us that we're trying to figure out what is the best way to go. Mm-hmm. And I would
like
add,
to.
Sorry, go ahead.
Oh, no, go ahead.
I was just going to add, one of the things that is really tricky when you only test once, as we did, we don't know whether the person who came back positive has been positive for 2 weeks or just turned positive yesterday. So we're not really sure how many of them are really actively infectious. So there's an issue there. And I think what we're learning is you probably have to do repetitive testing to really understand whether this is like the general population or something different. So just another one of the many confusing things of not having enough testing.
I would like to go to another question from Slido that we received from Kevin in Lowell. And he wanted to know, is testing for the prison and homeless populations prioritized? Are they given some sort of priority? And what kind of care is being given in those communities? Jim, maybe you would like to start?
Sure, and it's a great question. So testing, as everybody knows, is very, very difficult to get, has been up until now, and hopefully it will begin to open up. And I have to salute our state and city governments. When we sort of first presented that the testing at Pine Street showed so much, they've been working very, very hard to make sure we have adequate testing, at least to test people in the shelters. And I know, as you probably heard now, that the mayor has gotten hold of 1,000 extra tests, and we're testing virtually everyone in the Boston shelters now, as they have been doing in Worcester. But in truth, I think the state's in a bind because they only have so many tests, and where do you prioritize those tests to go? And since it's just not enough, I think our state is doing as good a job as I can imagine them doing, with the hope being that there'll be more tests coming. Now, one of the interesting things that I think this question is asking, and this is where I have to tip my hat to Lindia Downey at Pine Street Inn, and to Barry Bach, who's our dynamic CEO, and our staff. That night when remember these test results came back about a day or two later, and when we found out, oh my goodness, 147 people in the shelter are positive, we all collectively had to find places for them to go. And our respite program, sort of led by Dr. Dave Munson, who used to be on the street with me, and Suzanne Armstrong, created the third floor into a 52-bed COVID unit, which was pretty astonishing to do. And then the mayor, with the Boston Public Health Commission, secured the old Kindred Hospital in Brighton, which had been closed, was slated to be condominiums. And we were able to bring about 84 people who are COVID positive over there to take care of them. And all this was in anticipation of the 500 beds that are now open for homeless people with COVID positivity in the Boston Convention Center. So I think that that was a really interesting and wonderful strategy by the city, led by the city, that allowed us to then have places for COVID positive people to go. But I certainly recognize that that's not available in many cities, and it is a major issue.
Right, and following up on that, I found out that I think only about, I shouldn't say only, but about 100 people are currently occupying beds of the 500 that have been designated for people who are homeless at the Boston Hope Field Hospital and the 50 or so beds that you have at your South End Respite facility. So there are about 100 people receiving care in those beds right now. And just as a follow-up to that, in addition to setting up field hospitals and isolation centers, the state has set up a number of isolation centers for people who are homeless who've tested positive but don't need care in a hospital or even a field hospital. And they've set up facilities like that in hotels scattered around in different regions. But in addition to that, shelters have been making efforts to depopulate, so spread out their shelter populations just so the main shelters are not so crowded, so the virus isn't as easy to spread. And a shelter provider on the South Shore, John Yazwinski from Father Bill's in Mainspring, told us he thinks the state needs to come up with a plan to have those extra shelter spaces for many months to come, because some of them are in places that are going to want to open back up for business, a YMCA, a hotel, things like that. Some of them are tents that will be allowed to stay open for some time. But his point was that we can't just start moving people all back into the shelters in a month or so when business starts opening up again and the state starts reopening, if that happens in about a month, that this needs to happen for many months, possibly until there's a vaccine, so that the shelter population isn't all crowded in these facilities. Would you agree with that? What do you say about that?
Oh, I would certainly agree with, and John's wonderful. I think if, this is an opportunity to relook at how we have people live together in shelters, and to have large numbers of people crowded in the shelters, clearly not a great way to go. And I think if this example of how to decant the shelters, give people more space, shows us a way out and we can maintain that, that would be really wonderful. I am skeptical of what will happen. I know, for example, the city of Boston is working like crazy to house the chronically homeless and has been doing a great job. But to get the housing to scale quickly is a real difficult labor. So I worry a little bit about, and we're running into this now, for example. So when people are finished with their 2 weeks after they've had COVID and they're now are now okay, maybe or maybe not immune for a while, where do they go when we let them go? Because you don't want them to go back to the shelter and crowd out, but we don't have many other places to go other than the dormitories or if hotels open. So I think this is a time for cities to get together and really look carefully at the overall plan for what you want to do with homeless people as days go on and years go on.
Right, and hopefully we can talk about that housing issue a little bit later. Deb?
Mm-hmm.
Yeah, I think one thing, when we were thinking about having this virtual town hall and including vulnerable groups like those who are homeless and those who are incarcerated, we wanted to talk about how these worlds intersect, right? Because obviously there is a lot of intersection. And I'll say I interviewed men just recently who were released from prison and are now recovering from COVID-19 at the field hospital that was set up in Boston that Jim mentioned. So the two of you are doing work in very similar populations, sometimes the same people. And I wonder, we got a lot of questions on Slido about this. Can jails and prisons better quarantine folks and make sure they get care? And why should people be released? Because we'll talk about the fight to release folks in a minute. But is it safer almost for people to be in a place where they maybe can be more easily isolated and locked in than it might be out on the streets? And are there the services on the streets if there's a massive effort to decarcerate? I'd like both of you to sort of weigh in on that, what you think about that. So Liz, you first.
Yeah, absolutely. So, I think you just heard Jim talk about the mobilization that's happened for the homeless community in the Boston area, at the very least, which is where most people are actually released to when they are released from prisons and jails. So I think the answer is no, they can't be more safely quarantined in prisons and jails, particularly in prisons, because there just isn't the space. Most of the Department of Correction prisons are beyond design capacity right now. So they're just in the entire Department of Correction, there are less than 130 actual infirmary beds. So treatment beds, if you will. And the infirmaries are almost always full. Even before COVID came about, the infirmaries were mostly full already. So there just isn't the capacity to treat this number of people who, if they become really sick, and as many of us know, prisoners are disproportionately suffering from chronic conditions as well, the same conditions that Jim mentioned, and as you mentioned, these are largely the same people that we're talking about, who have cancer and liver disease and heart disease, and so they're more at risk for dying from COVID. There isn't enough space to quarantine everyone who's testing positive, especially if we continue to see the numbers that we're seeing now, where people is testing at like 50%, right? And so if those numbers continue to be demonstrated in various facilities, you're not going to be able to quarantine half of the population in each prison. So, and not appropriately. And we're already hearing from many clients in different prisons across the state that symptomatic people are being quarantined together. And then they test people. And what happens, of course, is that one of those individuals tests positive for COVID and the others test negative, but days later they become sick because they caught COVID from the person who was positive and then test positive for COVID. So there's not appropriate quarantining already right now happening with the numbers that we're seeing of people who have tested positive for COVID. And we know the numbers are much higher than that. And in terms of treatment, we have heard a number of concerning stories of people really, they're having their vitals checked and things like that. But we know that this disease can progress very quickly, and people can become in distress very quickly. And with the lockdown situation, what you have is less medical rounds happening, because that's what happens in a lockdown. And there's also possibly a staffing issue, which we heard was an issue for some time. So you may have people progressing and getting very sick very quickly and getting to the hospital much too late. And I suspect that's what happened with some of the people who have already passed. And just on the issue that Jim was talking about, and you've raised, Deb, around social distancing, this is about social distancing. We need to be able to spread people out so that the disease isn't transmitted. And that's not possible in prisons. We're not all home from our jobs because we don't have soap and water in our workplaces, and we don't have disinfectants to clean tables and high touch surface areas. We have all that in our workplaces for the most part, but that's not why we're home. We're home because it wasn't worth the risk of having people together in those settings, but yet we've decided to allow that to happen for a lot of these vulnerable populations, and we're behind the 8 ball in really addressing that problem. Although I'm very happy to hear that space has been created for the homeless. And of course, that space should be available to people being released from prisons and jails.
But are there services, do you think, in the community to accommodate more folks who may have difficulty and need services and support at this time?
Absolutely. And like I said, we're getting in a given week, we're getting dozens of phone calls, emails, Facebook messages from families and loved ones who are ready to accept their loved ones in their homes. It's not about accepting people who are necessarily so ill that they can't be in a home. Many people are ill, but just like they can be in their cells in a prison, they can be in their families' homes, quarantining much more safely than they can in a prison or a jail. And I think some people have heard of the group Families for Justice's Healing. They're families of incarcerated people or formerly incarcerated people who've been organizing for weeks and drawing attention to the fact that these are people who are ready to receive their loved ones. There are many, many people who have homes to go to. There are, of course, people who unfortunately would be released to a shelter anyway. And let's remember that that's the population Jim's dealing with. People are released every single day to shelters, and we've never had a problem with it before. And we should have. This is an issue that needs to be resolved systemically and needs a lot of attention and resources to think about, because as already has been mentioned, we could end up in this situation again in the future. We can't keep disadvantaging people who are in more vulnerable positions. And quite frankly, there's a very real disproportionate impact on communities of color as a result of this.
Jim, do you want to weigh in on that?
Just slightly, because I couldn't agree more with what Liz is saying. But I would just point out that for years, the intersection between jails and prisons and homelessness have been getting closer and closer. And I know it not so very long ago, if you had asked someone at one of the main shelters, like the city shelter or Pine Street, when a new person shows up at your door, about 50% of the time, the place they had slept the night before was in a jail. So that transition from jail to homelessness, just like from homelessness to jail, is a pretty fluid one. And I think we have a big challenge about how we would work to coordinate and care for folks. And one thing that has hampered us, which I'm sure Liz would agree with, is we can see somebody in a shelter clinic who has just spent the last 5 years in jail, but we will have no idea what happened with their health care, what was going on, and there is no housing available for them. So they are really kind of stuck going to the shelter with no support except whatever can be done. And I suspect the same problem hits the shelters, where they're seeing so many people who are suffering from severe mental illness, really critical medical problems, and substance use problems, and the jail is or prison is the one who then has to take care of that person, and it's very, very difficult. So I think there's a huge world that we could all learn from. And then I'd certainly underscore what is most uncomfortable about all of this, as you all know, is that this pandemic, like so many other things, when we watch people in homelessness in prisons, is just pointing out the sort of structural racism in our society, that poverty plays a huge issue. And it's just, there's been a glaring light shown on this during this pandemic.
Well, let's just talk about efforts that have happened so far to release people from jails and prisons. The state, as of I think today, released a report saying that more than 800 people have been released from state jails and prisons in an effort to make sure that they could do something to try to stem the spread of the virus. The state Supreme Judicial Court has issued a ruling that said some prisoners would be eligible for release, such as those being held pretrial and those on some probation and parole violations. And I guess, Liz, how many people do you think need to be released? And when you look at what other states are doing, who's doing it right? Is there somebody that's figured out a way to say, these are the steps we should take. We should make sure our prisons are at X level to help preserve public health? I mean, who's doing it right, and how many people should be released?
Yeah, thank you. So I think just to step back for a minute, there was a case in the Supreme Judicial Court, CPCS, which is the Public Defender Organization, Massachusetts Association for Defense Attorneys, and the ACLU were involved in that lawsuit. And the result there was the court was willing to order new hearings for certain pretrial individuals who could be eligible for release. But those are almost all of them are in the counties, not in the Department of Correction, which is more overcrowded than most of the county facilities. So that decision does not really impact the Department of Correction. There have been releases from the Department of Correction, as there have been from every county jail in the state, and that's because dozens of people are released every day because they complete their sentences and they can't be illegally held. And so they're released, not pursuant to COVID, just because they're wrapping their sentences or were already going to be released on probation or parole or whatever. So there's a large cohort of people that would have been released regardless of the decision. But the parties, particularly the CPCS, has been doing a lot of work around post-conviction relief for people who are sentenced, in addition to doing all the hearings for the pretrial individuals pursuant to the SJC order, so that some people who are sentenced but who qualify for unique reasons or because they have serious medical issues have been released, but also not pursuant to the order. The last count I saw from the DOC was around a dozen people. And again, none of those people were released pursuant to the SJC order. The court, however, has said and urged the parole board, who has been very, very, I'd say, lax in trying to release people who have already been approved for parole or eligible for release or for parole eligibility, and how to expedite hearings around that, or people who are eligible for release pursuant to medical, compassionate release medical parole, as we call it here in Massachusetts. And the court also urged the governor, of course, to do more, which is within his power to do. But we haven't really seen that. So yes, there have been releases in Massachusetts, but the Department of Correction, which holds the most people in the state, has really not released many people. And again, only pursuant to those court orders. So, so we have a lot more work to do there to really provide some relief in the state prisons around this. And then in terms of who's doing it right, you know, I don't want to point to any one state in particular, because I think there's room for improvement everywhere. But certainly New Jersey released 1,000 people. Other states have released far more people, and people from their state Department of Correction, and not just from county jails. And so I think many other states have taken action in quicker than we have here in Massachusetts.
All right. I want to remind people who are tuning in right now that this is a WBUR virtual town hall. We're live streaming with Dr. Jim OConnell, who's president of Boston Healthcare for the Homeless Program, and Lizz Matos, who is executive director of Prisoners Legal Services of Massachusetts. We are taking questions. You can submit your questions at slido.com, and the event code is WBUR-VTH3.
Dr. OConnell, I would like to get back real quick to the testing. You mentioned that the city of Boston did secure enough tests to complete universal testing of the homeless population. And we have some figures to show where that stands right now. We'll get to those in a minute. First, a couple of pictures from Southampton Street Shelter, which is one of the shelters that is where the population is being tested. That's the men's public shelter run by the Boston Public Health Commission. We have a picture from a couple of years ago of the dining and common area, and another picture of men waiting in line to get blankets, which they have to do every day. Normally, I know things have changed now in terms of efforts to socially distance and not have people gathering in lines closely like this. But this is one of the shelters where the universal testing is happening. And so far, the city has tested 1,370 people in the homeless community. And as of today, 466 of them, or 36%, have tested positive. So again, it seems like every place where the whole population is tested, it's somewhere in that 35 to 45% range. But I'm wondering, what do you do with these numbers moving forward? How long are they actually useful? Because someone can test negative and then be positive a few days later. The population is out, transient, moving around on the street a lot during the day. So how long are these numbers useful? It doesn't seem there's a plan to test the entire homeless community continually, and the other communities don't have the access to these tests. The state did tell us that it's working a lot with community health centers to increase access to tests for homeless shelters and homeless populations in various communities. Different cities and towns are working with their community health centers on that. But how long are they useful? Is this something that really needs to happen for a long time to come, testing over and over again?
We worry a lot, as you are suggesting, Lynn, that a single universal test gives you one point in time, but doesn't really help you going back too far, and going into the future doesn't help you that much. What it has allowed us to do is, first of all, this was a staggering, think of it, 36 to 40% of everybody in the shelters is turning positive. But as we do the testing, and as the city does the testing, we then remove those people from the shelters, bring them to, I should have mentioned one other absolutely heroic thing, which I should shout out to Kate Walsh, who's a visionary director, president of Boston Medical Center. They've opened the East Newton campus, which is a 250-bed campus that was going to be the Shattuck Hospital, and the state allowed the city to open that up. And that's going to be where, along with the 500 beds there, where homeless people as well as others can go to recover. So as each testing day, and right now the way the mayor has it, which is quite wonderful, is we're doing about 100 tests a day for the next 10 days, but each day brings another 30 or 40 people who are COVID positive that need to be removed or need to be isolated. And that's a lot of work on everybody's part. So it's been yeoman's effort by the Boston Public Health Commission and all the staff in our program and the BMC and the convention center folks. So what we learned though is we'll have those people for maybe a week to 2 weeks, and then they're able to be released. So when I think of flattening the curve in one way, as long as 30 or 40 are coming a day, and then we have enough beds for them, and then they'll empty out as we bring in more. So that is just the one time now only issue. What we really would love to do, and everyone acknowledges this, is to retest regularly, to do serial testing, so you know when the virus is beginning to spread even more. So to get control of this, I think one-time testing is really not a way to get control of it. It's a way to minimize it. But I think to get control, we have to do serial testing. I know that in Worcester now, I spoke with Dr. Garcia there, and they're trying to do serial testing at that shelter in Worcester. It'll be very interesting to see what that can do. And the other thing that I think is really worth mentioning is, we're doing serial testing now that there's a surge. And, as we think back, wouldn't it have been nice if we had been able to, not serial, we've been doing universal testing. Wouldn't it have been nice if we could do it before there was a surge? So we could have caught the first 10 people. And when you have only 10 or 15, you could isolate them and do contact tracing. So contact tracing ultimately is going to be the way we're going to stop it from spreading. So frequent testing with contact tracing is really the place we want to get to be. When it's already 30 or 40% in a shelter, you can't do the contact tracing. So that's another real limitation to what we're doing.
Right, and a follow-up question to that that we received on Slido, Dawn, who is a nurse, expressed concern for people who are homeless but unsheltered, and she wonders, are those tests being done and tracked? So is anyone considering or already doing something like doing rapid tests on a van, bringing a van out to sites where people gather and live on the streets to test in those places?
No, and to Dawn, that's a question that is near and dear to my heart, since most of my clinical life is taking care of the street folks. There are many paradoxes and ironies in this epidemic. One is that I think if you're in a shelter, you're more likely to get the virus than if you're living outside. So many of our street folks, for example, do not want to go anywhere near a shelter because they think that's where they will get sick. And interestingly, up until now, we've seen very few street people come down with COVID positivity. And most of them have been tested by the hospitals when they hit the emergency room. And I can certainly tell you, so far we know of no street person, with the exception of one, who's come down with that. And that's when he went home to stay with his family for a while, and the family had it. And I've talked to my friends in LA, and think of LA, where there are 46,000 people living on the streets in tents and everything else. They know of, at this point in time, only 33 people, homeless people, that have COVID. So they're not seeing the 46% the way we are. And there's, some, I'm almost reluctant to say this, because in many cases, people living in their tents are isolating much better than people who are forced to go to shelters. So we'll have a lot to learn out of this. So I share that Dawn's concern for the street population. They ordinarily the ones who die 3 times the rate of people living in the shelters. But this is all an upside down world now. And I have a feeling they know they're safer staying outside, separated from people, than coming in. And sorry to say that out loud. It's almost like I don't even want to say it because it feels so upside down.
Right. I was going to ask about that, because the goal is always to have people sheltered, and Boston does such a good job of that. I think it's normally around 3% in recent years unsheltered, compared to some cities on the West Coast, Seattle and LA and San Francisco, that are something to around 67 to 70% unsheltered. And I was reading a story about people who are homeless sleeping on subway cars and in subway stations even more than normal right now, because they are wanting to escape the shelters. So I've wondered, what is going to happen now, especially that we're moving into warmer weather. Is it truly safer for people to be outside, and will more people choose to stay outside? But that leads me to ask more about the human toll and just what you're hearing and seeing in terms of the stress this is putting on people, the anxiety you're hearing about, all these people who are already at a tough point in their lives and dealing with a lot of difficult challenges. And many of them finding out they have the virus, they have to be moved to a different location out of the shelter into an isolation facility, then maybe moved somewhere else. In addition to the people having true health challenges as a result of this. What are you hearing just about the stress and anxiety that people are facing as a result of this?
There's a considerable amount of anxiety among the people. And you can imagine if you're trying to get into a shelter and somebody tests you and you're now positive, but you haven't felt anything, and then we're saying you've got to go somewhere else to stay isolated, that feels really difficult for people that are used to being independent and pretty feisty. So that's been difficult. What's interesting to me, if I step back though, is much of what is going on is highlighting what misery and what suffering people go through ordinarily in shelters. So when you talk to somebody in the shelter or somebody living outside chronically and you say there's this virus coming, we want to protect you, they kind of write that off and say, look, I'm facing death and exposure and everything else every day. A little virus is not frightening me. And they tend to not take it as seriously as we're taking it. So most of our time we're trying to convince them that this is an important thing to do. But they struggle to survive every day, face death, and this is not a big deal. So that I worry about a little bit. The other thing that has struck me as we've done this for years, most homeless people are pretty much have been cut off from their families and friends and everything else. And when they go to the hospital and when they're really suffering, they tend to be very alone and very lonely. And we've watched innumerable people die all by themselves with no one around in ways that just break your heart. And we're watching now in this coronavirus thing, now we're watching people in ICUs who can't have their loved ones around. And it's really heartrending. But interestingly, it's kind of what homeless people have been living through because of the way our system is set up for years. So they don't even worry about that the same way you might, like I would worry. I'd hate to go into the hospital now and know that my family could not come see me. But that does not scare them. So there's really interesting perspectives that need to be taken care of and respected. On our board of directors, by the way, we have several homeless people, and they've been pretty much our guides on how we should be looking at this and doing it. And they're very cognizant of how difficult this is for homeless people right now and how it shows them how poorly they've really been treated for years, not just now.
Right. And to clarify one thing, you talked about a lot of people dying alone. I think you're talking in general over the years that you've been doing this work. I think so far you said you know of 2 people in the Boston homeless community who have died. And you have had a handful or so, maybe slightly more than a handful that have been hospitalized in fairly serious condition. Is that correct? Just to clarify on that point.
Yeah, that's correct. Now, of course, just add that, there's many hospitals in Boston. There may be people that we don't know about, but we usually have a pretty good, through our network of shelter partners and everything, pretty good sense of that. And we only know really a very few who have been hospitalized, and there are 2 known deaths. There may be more, but we only know of 2 at a time when we were expecting much, much more.
Right.
I'm wondering, Liz, when it comes to releasing prisoners, you mentioned some of the legal action that's been going on, and I know we hear from a lot of folks. We have a lot of questions on Slido about this, but obviously, folks say that there could be a public safety issue. How do you make sure that public safety is preserved? How do you make sure that it's safe to release some people from jails and prisons? We have a question from Anonymous, and briefly, if I could just summarize, this person says, what about public safety? How does releasing prisoners increase public safety? And our state officials say what they're doing is the prosecutors and the sheriffs and DOC say they are evaluating cases and trying to make a determination as to who can be safely released in an effort to promote social distancing in correctional facilities. So what do you say about striking this balance, Liz? How do people strike the right balance between public health and public safety?
Yeah, I think there are a lot of myths and misinformation about how this gets done. And in one prevailing idea has been, well, how could they possibly figure out, who to release in the sentence population? but we have to remember, and I think this is one of the reasons why the Supreme Judicial Court is focused on the parole board. There are people who have already been approved for parole, meaning the parole board and the DOC have determined that this person is a low risk, is not a risk to public safety, and should be released. And so we should be releasing those individuals. And for other people who have hit their parole eligibility date, the push has been to expedite those hearings and look at who is a low public safety risk and doesn't pose a threat to public safety and can be released. And again, the Department of Correction and the parole board do risk assessments all the time on individuals who are incarcerated. So they know who is a low public safety risk. And that also, I think there's a misunderstanding that low public safety risk means people who have not been convicted of quote unquote violent offenses, which can be possession of a firearm. Just to clarify that there's a big range there. But for a lot of the sick and elderly, we're talking about people who've been incarcerated for decades, who may have been incarcerated at age 18 or 19 for a violent offense, but 30 years later, they're still incarcerated. They're now infirm and elderly, and by definition, you age out of crime, around 30, 40 years of age, and you become much more low risk. So the elderly in particular are some of the lowest risk people in the system. And then you add to that infirmity, there are many people who are very low public safety risk and should be assessed for release on that basis. Just because someone has been sentenced doesn't mean that they're not appropriate for release.
Mm-hmm. So you think there are appropriate risk assessment tools in place right now that could pretty much guarantee if someone was released, they could be safely released in order to deal with this pandemic?
Yeah, not only that, but a large body of research, including the department's own research, about people who are low risk because of age and infirmity. That is, there's a ton of research on that all around the country about how these are the lowest risk offenders and people age out of crime. So that is a known fact. It's not just an idea or a theory. But also, we have to remember the Department of Correction, not that long ago, used to furlough people, allow prisoners to furlough and go home, including first-degree lifers. So people who have been convicted and serving life sentences for murder would go home and spend time with their families and come back. It was a very successful program, and the Department of Correction itself has reports that attribute its lower recidivism rate at that time, far lower than it is today, to the success of its furlough program. But we ended that program because instead of being evidence-based in Massachusetts, we were reactionary in the Willie Horton days. And that reactionary political response has unfortunately really caused our system to be much less public safety based and more reactionary.
But I wonder, and because we're going to wrap up soon, and I want to make sure I get this in at the same time. As this is happening, as law enforcement officials are saying, we're taking steps to release people. Perhaps we won't hold people on technical violations and incarcerate them. As police officers say, we're not arresting as many people. We're looking at alternatives so we don't send people into correctional settings where they might be at risk of contracting the virus. I mean, do you think that this pandemic could lead to longer lessons that might result in criminal justice reforms because of what's being experienced right now, because of 800 people being released from prisons, even if that's not totally because of the pandemic, and because of some of these other steps that we're hearing about where sheriffs and DOC officials and prosecutors are sitting down and saying, okay, who can get out?
I think there's certainly an opportunity for that. And I think we have people in law enforcement who actually believe in that, but it will really depend on, again, political will and also on the role of these correctional administrators in really being willing to shift resources away from what is largely a punitive and not very rehabilitative system to putting systems in place in our communities to care for people who need care. as Jim's already stated, he sees these people cycling in and out and back and forth between, jails and prisons and homelessness. And the reason is because there's a lack of housing, there's a lack of opportunities for job placement, and our communities and our society just don't do a good job of helping people reintegrate into society. There's a lot of funding that's been lost over many years for reentry services, real reentry services, taking people and actually helping them and giving them the tools they need to succeed on their own. And that's really done a disservice to the population. But if we're willing to actually shift resources, focus on rehabilitation, focus on reentry, and providing the services people need in the community, then yes, I think this could be a really great opportunity. One of the few opportunities we have in this terrible situation. But I think it will depend on a lot of factors that have yet to reveal themselves.
Jim, if we could come back, we just have a few minutes left. I know you touched on the housing issue earlier. I think it's a good place to wrap this up. I think if anything, this pandemic has put the need for housing into even more, stark relief. And people who've been working in this area for years now have been trying to get people more quickly into permanent supportive housing and saying we have to stop warehousing people in these shelter facilities. There's, of course, a drastic shortage of that permanent housing with support services tied to it. There's a drastic shortage of all kinds of housing. And right now, I'm sure people want to be getting people, the advocates and homeless shelter, homeless service providers want to be getting people into housing even more now with this pandemic going on, wanting to get them out of shelters to be safer. The pandemic clearly makes that harder with so many things shut down. But where does it leave you thinking about housing, and will this contribute to anything changing in terms of housing really being scaled up?
Well, I think it could not make more clear the fact that housing, like all of us can do, we can all go to our homes and isolate and quarantine. And I think that's the right of everybody. And we should be, if ever in time in our history, we should be acknowledging that's what we need right now. We really need housing for all of these folks. What I worry about is my skepticism that we can scale up housing to meet the current need. And how do you care for those people who are waiting to get housing? And the other problem, I think, I've often thought, as you all know, and I'm sure you've heard me say, is that the more we learn about housing, it's clearly, more learn about homelessness, it's clearly a problem of not only housing, but it's a problem of education, and it's a problem of welfare, and it's a problem of jobs, and it's a problem of income equality and, racial issues. And we have to fix all of those. And I worry that we might focus on one in this point and not catch the whole picture. And, I guess I've been struck by poor housing is not what we're looking for. We're looking for housing like we would all want for everybody. And I worry that in this, strive to get people somewhere, that we'll put them in inadequate housing. And the issue that comes across me as I've learned from our MGH colleagues, the city of Chelsea is got as the worst problem we know of in the Commonwealth. And that's a problem of crowded housing. It's not a crowding of homelessness. It's a problem of too many people in too crowded a housing. And I think we've got to be smart and say we want to get everyone, the citizens of Chelsea and the people who are in shelters and, in wherever they are in crowded situations, into decent housing in good neighborhoods with enough space. And I think that's, I used to think that was way out of reach, but now that I see trillions of dollars put into rescue packages, maybe it isn't quite so out of reach if we can just elevate that consciousness at this point. That would be really nice.
Well, that wraps up our WBUR virtual town hall. We would like to thank our guests, Dr. Jim OConnell, president of Boston Healthcare for the Homeless Program.
Thank you so much.
And Lizz Matos, executive director of Prisoners Legal Services of Massachusetts. Lizz, thanks for being with us.
Yes, thanks so much for doing this.
Yeah. And I also want to thank the City Space team. They made it technically possible. So thank you, City Space team. And thanks to everyone who tuned in tonight. Thank you, Lynn.
Thank you, Deb. And we hope you can join us again next Tuesday evening for our next WBUR virtual town hall. Reporter Callum Borchers will be talking about the societal costs of COVID-19 with Boston University School of Public Health Dean Dr. Sandro Galea. Thank you so much for joining us. Have a good rest of the evening and be well.